All right, let's talk about something you're absolutely going to see on the ABSITE and, more importantly, in your surgical ICU, hypernatremia. Now, this isn't just about chasing a lab value, it's about really understanding the art of water balance in your sickest patients. So let's get right into it.
So, you might be wondering, why does a sodium of, say, 152 make a seasoned intensivist a little nervous? What's the big deal? Well, it's because that little change is actually a huge red flag. It's a signal of a much deeper and potentially deadly problem that's going on with your patient.
Okay, the textbook definition is a serum sodium over 145, but I want you to burn this into your brain. Hypernatremia is not a salt problem. It's a water problem. It means your patient is seriously dehydrated on a cellular level, and it's our job to figure out why and, how to fix it safely.
And the stakes here are incredibly high. This isn't just some number you correct. Hypernatremia is an independent predictor of death. Look at this. When that sodium gets above 150, the mortality rate can jump to almost 50%. That is a number that demands your full attention.
So to really get a handle on this, we're going to tackle it like an investigation. First, we'll cover the basic principles: water, hormones, and the brain. Then we'll profile our patient based on their volume status. After that, we'll get into the essential calculations, run through the correction playbook, and finally, test our skills on some real bedside cases.
So, first things first, we have to start with the fundamentals. If you can really grasp the basic physiology of how our bodies manage water, everything else we talk about is going to click into place.
This one sentence right here, it changes everything. Your patient's serum sodium is really just a reflection of the ratio between their total body salt and their total body water. So when that number goes up, it's almost always because the water part of that equation has gone down. So on the ABSITE, the first thing you should think is this a water problem?
Our bodies have this beautiful, elegant system to keep this from happening. Super sensitive sensors in the hypothalamus can detect a change in concentration as small as 1%. That tiny change triggers the release of ADH, or antidiuretic hormone, which basically tells the kidneys, hey, hold on to water. It does this by putting these little water channels, called aquaporins, into the collecting ducts. And if all else fails, the brain's ultimate backup plan is simple: thirst.
And this, right here, is the central problem in the ICU. Our patients often can't use that final life-saving defense. They're intubated, they're sedated, they might be neurologically out of it, they can't tell you, I'm thirsty. Their safety net is gone, which means we have to become their thirst mechanism.
Now, the brain is where things get really dangerous. In an acute situation, high sodium in the blood literally pulls water out of brain cells, causing them to shrink. This can actually tear the delicate veins in the brain. But over a couple of days, the brain does something amazing. It adapts. It creates these things called idiogenic osmoles inside its cells to pull water back in and plump themselves up again. It's a brilliant survival move, but it also sets a very dangerous trap for us.
And here is that trap. If you see a patient with chronic hypernatremia and you correct their sodium too fast, you're going to cause a catastrophe. The bloodstream suddenly becomes way more dilute than the inside of those adapted brain cells. Water floods into the brain, causing massive swelling or cerebral edema. That's why for any chronic case, the mantra is slow and steady. We're talking no more than half a point per hour.
Okay, so we've got the physiology down and we understand the risks. You're at the bedside. You see a high sodium. What's step one? The very first thing you do is figure out your patient's volume status. Are they dry? Are they wet? Or are they somewhere in the middle?
Every single case is going to fall into one of these three buckets. The most common is hypovolemic, where they've lost both salt and water, but way more water than salt. Then there's euvolemic, which is a pure water loss, usually from something like diabetes insipidus. And finally, hypervolemic, which, let's be honest, is usually our fault. It's iatrogenic from giving too much salty fluid.
So once you know your patient is hypovolemic, a couple of simple urine labs will tell you where the water is being lost. If the kidneys are the problem, maybe from diuretics, they're wasting salt, so the urine sodium will be high. But if the problem is outside the kidneys, like from an NG tube or diarrhea, the kidneys are actually doing their job perfectly. They're holding on to salt for dear life, so the urine sodium will be low and the urine will be super concentrated.
All right, let's get practical. To really treat this right, you need a couple of key formulas in your back pocket. This is how we go from just having a diagnosis to having a real quantitative plan.
First up, the free water deficit. This formula is your starting point. It tells you,
in liters, exactly how much pure water your patient is missing to get back to a normal sodium. Think of it as calculating the patient's existing water debt.
But here's the next level move. You also have to track electrolyte-free water clearance. This basically calculates the ongoing leak in the system. It tells you how much pure water your patient is losing in their urine right now. If you don't account for this leak, you'll just be treading water as their sodium keeps creeping up.
So we have a diagnosis, we've done our calculations, now it's time to actually execute the plan. The correction playbook is all about doing things safely, at the right time, and with the right fluids.
And here are your hard and fast safety limits. If it's acute, meaning it happened in the last 48 hours, the brain hasn't adapted so you can go a bit faster. But if it's chronic, or if you have no idea how long it's been going on, you have to follow these rules. No faster than half a point an hour, and an absolute max drop of 8 to 10 points over 24 hours. This is how you prevent that catastrophic cerebral edema.
Now, this might be the single most important rule of all. Perfusion always, always trumps tonicity. If your patient is in shock, if their blood pressure is in the toilet, you give them isotonic fluids, like normal saline or LR first. You fix the shock. Don't even worry about the sodium yet. Once they're stable, then you can switch to hypotonic fluids to start fixing the water problem.
Okay, you have the knowledge, so let's put it into practice. We're going to run through a classic high-yield scenario that I can almost guarantee you'll see both on your exam and in real life.
So picture this. You get a call. Your patient is 6 hours post-op from pituitary surgery, and they are just pouring out urine, 650 milliliters in 1 hour. Their sodium is climbing, and when you check their urine, it's incredibly dilute.
So, based on everything we've talked about, what's your move? What's the single most important thing you need to do right now? Think back to the physiology. What's broken here?
The answer is to give desmopressin, or DDAVP. This is a textbook classic presentation of central diabetes insipidus. The pituitary gland has been stunned by surgery and isn't releasing ADH, so the kidneys have no signal to reabsorb water. Your job is to replace that missing hormone. This is an association you absolutely have to know.
And let's end on this thought. You can calculate the water deficit perfectly. You can start the right fluids. But if you're not actively tracking and replacing those ongoing losses, if we're not paying attention to the leak, your whole plan is going to fall apart. Mastering hypernatremia isn't just about fixing the problem in front of you. It's about anticipating and getting ahead of the next one, and that is the key.